Central nervous system pathology. Developmental anomalies. Neural tube defects. Neural tube defects result from incomplete closure of the neural tube during early embryonic development. The neural plate normally invaginates to form the neural tube, which extends along the cranial to caudal axis of the embryo. The wall of the neural tube gives rise to the central nervous system tissue. The hollow lumen forms the ventricles and spinal cord canal, and the neural crest gives rise to the peripheral nervous system. These defects are associated with low folate levels before conception and can be detected prenatally by elevated alpha-fetoprotein levels in the amniotic fluid in maternal blood. Anencephaly represents the absence of the skull and brain due to disruption of the cranial end of the neural tube, leading to a frog-like facial appearance of the fetus and resulting in maternal polyhydramnios because the fetus cannot swallow amniotic fluid properly. Spina bifida results from failure of the posterior vertebral arch to close, producing a vertebral defect at the caudal end of the neural tube. Spina bifida occulta presents as a small dimple or patch of hair over the defect, while the cystic form may involve meningocele, a protrusion of meninges, or meningomyelocele, a protrusion of both meninges and spinal cord. Cerebral aqueduct stenosis. Cerebral aqueduct stenosis is a congenital narrowing of the channel that drains cerebrospinal fluid from the third ventricle into the fourth ventricle, leading to accumulation of cerebrospinal fluid within the ventricular system and resulting in hydrocephalus. It is the most common cause of hydrocephalus in newborns. Cerebrospinal fluid is produced by the choroid plexus in the ventricles, flows from the lateral ventricles to the third ventricle through the interventricular foramen of Monro, from the third ventricle to the fourth ventricle through the cerebral aqueduct, and then into the subarachnoid space through the foramina of Magendie and Leuschka. Obstruction at the aqueduct causes dilation of the ventricles, and since the cranial sutures have not yet fused in infants, it presents with an enlarging head circumference. Dandy-Walker malformation. Dandy-Walker malformation is caused by congenital failure of the cerebellar vermis to develop, resulting in a massively dilated fourth ventricle in the posterior fossa and an absent cerebellum. This condition is often associated with hydrocephalus due to obstruction of cerebrospinal fluid drainage. ARNOLD-CHIARI malformation, type 2. ARNOLD-CHIARI malformation type 2 is characterized by congenital herniation of the cerebellar tonsils through the foramen magnum. This displacement can obstruct cerebrospinal fluid flow, leading to hydrocephalus. It is commonly associated with meningomyelocele and SYRINGOMYELIA. Spinal cord lesions. SYRINGOMYELIA. SYRINGOMYELIA is a cystic degeneration of the spinal cord that can develop following trauma or in association with an ARNOLD-CHIARI malformation. It most commonly occurs at the cervical levels C8 to T1 and presents with loss of pain and temperature sensation while preserving fine touch and proprioception in a cape-like distribution over the shoulders and upper extremities. This pattern results from involvement of the anterior white commissure of the spinothalamic tract with sparing of the dorsal column. As the syrinx expands, other tracts within the spinal cord become affected, leading to muscle atrophy and weakness due to lower motor neuron damage in the anterior horn and loss of muscle tone and reflexes. Disruption of the hypothalamospinal tract in the lateral horn produces Horner syndrome, characterized by ptosis, meiosis, and anhidrosis. Poliomyelitis. Poliomyelitis results from poliovirus infection causing damage to the anterior motor horn of the spinal cord. This leads to lower motor neuron signs, including flaccid paralysis, muscle atrophy, fasciculations, weakness, decreased muscle tone, impaired reflexes, and a negative Babinski sign with downgoing toes. WERDNIG-HOFFMAN disease. WERDNIG-HOFFMAN disease is an inherited autosomal recessive degeneration of the anterior motor horn. It presents as a floppy baby with severe hypotonia and weakness and is often fatal within the first few years of life. Amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis is a progressive degenerative disorder affecting both upper and lower motor neurons of the corticospinal tract. Degeneration of the anterior motor horn causes lower motor neuron signs, such as flaccid paralysis, muscle atrophy, fasciculations, decreased tone, reduced reflexes, and a negative Babinski sign, while degeneration of the lateral corticospinal tract leads to upper motor neuron signs, including spastic paralysis, hyperreflexia, increased tone, and a positive Babinski sign. Early symptoms often involve atrophy and weakness of the hands. Sensory function remains intact, distinguishing amyotrophic lateral sclerosis from syringomyelia. Most cases are sporadic and occur in middle-aged adults, though some familial forms are associated with a mutation in the zinc-copper superoxide dismutase gene, leading to free radical damage in motor neurons. Friedreich ataxia. Friedreich ataxia is a degenerative disorder involving both the cerebellum and spinal cord. Degeneration of the cerebellum causes gait ataxia, while degeneration of spinal tracts leads to loss of vibratory sense and proprioception, weakness in the lower limbs, and loss of deep tendon reflexes. It is inherited in an autosomal recessive pattern and results from an unstable trinucleotide GAA repeat expansion in the frataxin gene. Frataxin is essential for mitochondrial iron regulation, and its loss causes iron accumulation and free radical injury. The disease presents in early childhood, and affected individuals become wheelchair-bound within a few years. It is frequently associated with hypertrophic cardiomyopathy. Spinal cord tracts. The spinothalamic tract, responsible for pain and temperature sensation, begins with first-order neurons that travel from the peripheral nerves to the posterior horn of the spinal cord, with a cell body located in the dorsal root ganglion. The second-order neuron arises from the posterior horn, immediately crosses over in the anterior white commissure, and then ascends via the spinothalamic tract to reach the thalamus. The third-order neuron extends from the thalamus to the cerebral cortex. The dorsal column medial lemniscus pathway, which carries sensations of pressure, touch, vibration, and proprioception, begins with first-order neurons that travel from the peripheral nerves to the medulla via the dorsal column, with a cell body in the dorsal root ganglion. The second-order neuron arises from the medulla, crosses over to the opposite side, and ascends through the medial lemniscus to reach the thalamus. The third-order neuron projects from the thalamus to the cortex. The lateral corticospinal tract, responsible for voluntary movement, begins with pyramidal neurons located in the motor cortex that descend and cross over in the medullary pyramids, then synapse on the anterior motor horn of the spinal cord as the upper motor neuron. The second-order neuron arises from the anterior motor horn and synapses directly on the skeletal muscle as the lower motor neuron. There is no third-order neuron in this pathway. The hypothalamospinal tract, which carries a sympathetic input to the face, arises from neurons in the hypothalamus and descends to synapse on the lateral horn of the spinal cord at the level of the first thoracic segment. The second-order neuron arises from the lateral horn at the first thoracic level and synapses in the superior cervical ganglion, which is part of the sympathetic chain. The third-order neuron extends from the superior cervical ganglion to innervate the eyelids, pupil, and skin of the face. Meningitis. Basic principles. Meningitis is an inflammation of the leptomeninges, the layers of tissue that cover the brain and spinal cord. The meninges consist of three layers: the dura mater, arachnoid mater, and pia mater. The pia and arachnoid layers together are known as the leptomeninges. The condition is most commonly caused by an infectious agent. In neonates, typical pathogens include group B Streptococcus, Escherichia coli, and Listeria monocytogenes. In children and teenagers, Neisseria meningitidis is the most common cause, while Streptococcus pneumoniae predominates in adults and the elderly. Haemophilus influenza may affect non-vaccinated infants. Coccidiovirus, transmitted via the fecal-oral route, is a common viral cause in children, and fungal infections occur primarily in immunocompromised individuals. Clinically, meningitis presents with a classic triad of headache, neck stiffness, and fever. Other symptoms may include photophobia, vomiting, and altered mental status. Diagnosis is established by performing a lumbar puncture to analyze the cerebrospinal fluid. The procedure is done by inserting a needle between the fourth and fifth lumbar vertebrae, corresponding to the level of the iliac crest. The spinal cord terminates at the level of the second lumbar vertebra, but the subarachnoid space and cauda equina extend to the level of the second sacral vertebra, allowing safe access. The needle passes sequentially through the skin, ligaments, epidural space, dura mater, and arachnoid mater to reach the cerebrospinal fluid. Cerebrospinal fluid findings vary depending on the cause. In bacterial meningitis, there is an elevated neutrophil count and decreased cerebrospinal fluid glucose, and the causative organism is often identified by gram stain and culture. In viral meningitis, lymphocytes are predominant with normal glucose levels. In fungal meningitis, lymphocytes are also present but with decreased cerebrospinal fluid glucose. Complications occur mainly in bacterial meningitis and include death due to brain herniation secondary to cerebral edema, as well as long-term sequelae such as hydrocephalus, hearing loss, and seizures resulting from meningeal fibrosis. Cerebrovascular disease. Basic principles. Cerebrovascular disease refers to a neurological deficit caused by cerebrovascular compromise and is a major cause of morbidity and mortality. It occurs due to ischemia in most cases or hemorrhage in some. Neurons depend entirely on serum glucose as an energy source and are particularly susceptible to ischemia, undergoing necrosis within 3 to 5 minutes. Global cerebral ischemia. Global cerebral ischemia refers to a generalized reduction in blood flow to the brain. Major causes include low perfusion from atherosclerosis, acute decrease in blood flow from cardiogenic shock, chronic hypoxia, such as an anemia, and repeated episodes of hypoglycemia, as seen in insulinoma. The clinical features depend on the duration and magnitude of the ischemic insult. Mild ischemia leads to transient confusion with full recovery. Severe ischemia causes diffuse necrosis resulting in a vegetative state, and moderate ischemia produces infarction in watershed areas, such as the zone between the anterior and middle cerebral arteries. Highly vulnerable regions include pyramidal neurons of the cerebral cortex, particularly layers 3, 5, and 6, resulting in laminar necrosis. Pyramidal neurons of the hippocampus, essential for long-term memory, and Purkinje cells of the cerebellum, which integrate sensory input with motor control. Ischemic stroke. Ischemic stroke is caused by regional ischemia of the brain that produces focal neurological deficits lasting longer than 24 hours. When symptoms resolve within 24 hours, it is called a transient ischemic attack. Subtypes include thrombotic, embolic, and lacunar strokes. Thrombotic stroke is caused by rupture of an atherosclerotic plaque, commonly occurring at arterial branch points, such as the bifurcation of the internal carotid and middle cerebral artery in the circle of Willis, leading to a pale cortical infarct. Embolic stroke results from thromboembolus, most commonly originating from the left side of the heart in conditions such as atrial fibrillation. It typically affects the middle cerebral artery and causes a hemorrhagic infarct at the cortical periphery. Lacunar stroke occurs due to hyaline arteriolosclerosis, a complication of hypertension, most often affecting the lenticulostriate vessels and producing small cystic infarcts. Involvement of the internal capsule produces a pure motor stroke, while involvement of the thalamus results in a pure sensory stroke. Microscopically, ischemic stroke shows liquefactive necrosis with early eosinophilic change of neurons, known as red neurons, within 12 hours. Followed by coagulative necrosis at 24 hours, infiltration by neutrophils within 1 to 3 days, microglial infiltration between 4 to 7 days, and granulation tissue formation in 2 to 3 weeks. This eventually leads to a fluid-filled cystic cavity surrounded by gliosis. Intracerebral hemorrhage. Intracerebral hemorrhage refers to bleeding within the brain parenchyma, most commonly caused by rupture of Charcot-Bouchard microaneurysms involving the lenticulostriate vessels. This condition is a complication of chronic hypertension, and controlling blood pressure significantly reduces the incidence. The basal ganglia is the most frequent site of bleeding. Clinically, it presents with a severe headache, nausea, vomiting, and progression to coma. Subarachnoid hemorrhage. Subarachnoid hemorrhage is bleeding into the subarachnoid space. It presents classically with a sudden onset of severe headache described as the worst headache of life, accompanied by neck stiffness. Lumbar puncture shows xanthochromia, a yellow discoloration of the cerebrospinal fluid caused by bilirubin breakdown. The condition most commonly results from rupture of a Barry aneurysm, while other causes include arteriovenous malformations and anticoagulated states. Barry aneurysms are thin-walled saccular outpouchings that lack the tunica media, predisposing them to rupture. They are most often located in the anterior circle of Willis at the branch points of the anterior communicating artery. Barry aneurysms are associated with Marfan syndrome and autosomal dominant polycystic kidney disease. Trauma. Epidural hematoma. Epidural hematoma is the collection of blood between the dura mater and the skull. It is classically caused by a fracture of the temporal bone with rupture of the middle meningeal artery, leading to arterial bleeding that separates the dura from the inner surface of the skull. Computed tomography scan shows a lens-shaped lesion. A lucid interval may occur before the onset of neurological symptoms. Herniation is a fatal complication of epidural hematoma. Subdural hematoma. Subdural hematoma refers to the accumulation of blood beneath the dura mater, covering the surface of the brain. It occurs due to tearing of the bridging veins that traverse between the dura and the arachnoid layers, commonly following trauma. Computed tomography scan demonstrates a crescent-shaped lesion. The condition presents with progressively worsening neurological symptoms. It is more common in elderly individuals due to age-related cerebral atrophy, which stretches and weakens the bridging veins. Herniation is a potentially lethal complication. Herniation. Herniation refers to the displacement of brain tissue resulting from mass effect or elevated intracranial pressure. Tonsillar herniation involves downward displacement of the cerebellar tonsils through the foramen magnum, causing compression of the brainstem and leading to cardiopulmonary arrest. Subfalcine herniation involves displacement of the cingulate gyrus beneath the falx cerebri, resulting in compression of the anterior cerebral artery and subsequent infarction. Uncal herniation involves displacement of the temporal lobe uncus beneath the tentorium cerebelli. Compression of the oculomotor nerve causes the eye to deviate downward and outward with a dilated pupil. Compression of the posterior cerebral artery leads to infarction of the occipital lobe, resulting in contralateral homonymous hemianopsia. Rupture of the paramedian artery in this setting may cause durate hemorrhage within the brainstem. Demyelinating disorders. Basic principles. Myelin insulates axons to enhance the speed and efficiency of nerve impulse conduction. Oligodendrocytes are responsible for myelination in the central nervous system, while Schwann cells perform this function in the peripheral nervous system. Demyelinating disorders are characterized by the destruction of myelin or oligodendrocytes, with relative preservation of the underlying axons. Leukodystrophies. Leukodystrophies are inherited disorders caused by mutations in enzymes required for the production or maintenance of myelin. Metachromatic leukodystrophy results from a deficiency of aryl sulfatase, inherited in an autosomal recessive manner, and is the most common leukodystrophy. In this disorder, myelin cannot be degraded and accumulates within the lysosomes of oligodendrocytes, resulting in a lysosomal storage disease. Crab disease is caused by a deficiency of galactocerebrosidase, also inherited in an autosomal recessive pattern, leading to the accumulation of galactocerebroside within macrophages. Adrenoleukodystrophy results from an X-linked defect that impairs the addition of coenzyme A to long-chain fatty acids, causing accumulation of fatty acids that damage the adrenal glands and the white matter of the brain. Multiple sclerosis. Multiple sclerosis is an autoimmune disease characterized by destruction of central nervous system myelin and oligodendrocytes. It is the most common chronic central nervous system disorder in young adults between 20 and 30 years of age and is more common in women. The disease is associated with the HLA-DR2 allele and occurs more frequently in regions distant from the equator. It presents with relapsing neurological deficits followed by periods of remission, representing multiple lesions in both time and space. Clinical features include blurred vision in one eye due to optic nerve involvement, vertigo, and scanning speech due to brainstem lesions, internuclear ophthalmoplegia due to damage to the medial longitudinal fasciculus, hemiparesis or unilateral sensory loss from cerebral white matter involvement, typically near the ventricles, lower extremity sensory loss or weakness from spinal cord lesions, and bowel, bladder, or sexual dysfunction due to autonomic nervous system involvement. Diagnosis is based on magnetic resonance imaging and lumbar puncture. Magnetic resonance imaging reveals white matter plaques indicating demyelination. Cerebrospinal fluid analysis shows elevated lymphocytes, increased immunoglobulins with oligoclonal immunoglobulin G bands on high-resolution electrophoresis, and the presence of myelin basic protein. Gross pathology demonstrates gray-appearing plaques within the white matter. Acute attacks are treated with high-dose corticosteroids, while long-term therapy with interferon beta can slow disease progression. Subacute sclerosing panencephalitis. Subacute sclerosing panencephalitis is a progressive and fatal encephalitis caused by a slowly progressive persistent infection of the brain by the measles virus. The initial infection occurs in infancy, but neurological symptoms develop years later during childhood. Histopathological findings reveal viral inclusions within neurons in the gray matter and within oligodendrocytes in the white matter. Progressive multifocal leukoencephalopathy. Progressive multifocal leukoencephalopathy results from reactivation of the JC virus, which infects oligodendrocytes in the white matter. Immunosuppressed states, such as acquired immunodeficiency syndrome or leukemia, allow reactivation of the latent virus. The disease presents with rapidly progressive neurological deficits, including visual loss, weakness, and dementia, eventually leading to death. Central pontine myelinolysis. Central pontine myelinolysis is characterized by focal demyelination of the pons located in the anterior brainstem. It occurs due to rapid intravenous correction of chronic hyponatremia, typically in severely malnourished patients, such as alcoholics or those with liver disease. The classic presentation is acute bilateral paralysis, also known as locked-in syndrome. Dementia and degenerative disorders. Basic principles. These disorders are characterized by progressive loss of neurons within the gray matter, often resulting from the accumulation of abnormal proteins that damage neuronal structures. Degeneration involving the cerebral cortex primarily leads to dementia, while degeneration affecting the brainstem and basal ganglia results in various movement disorders. Alzheimer's disease. Alzheimer's disease is a degenerative disorder of the cerebral cortex and represents the most common cause of dementia. It presents with a gradual onset of memory loss, beginning with short-term memory impairment and progressing to long-term memory loss accompanied by disorientation. Patients experience loss of learned motor skills and language abilities, along with changes in behavior and personality. As the disease advances, patients become mute and bedridden, with infections often serving as the terminal event. Focal neurological deficits are typically absent in the early stages of the disease. Most cases are sporadic and occur in the elderly, with risk increasing with age, doubling approximately every 5 years after the age of 60. The presence of the E4 allele of apolipoprotein E is associated with an increased risk, while the E2 allele is associated with a reduced risk. Early-onset Alzheimer's disease occurs in familial cases linked to mutations in the presenilin-1 and presenilin-2 genes, and also in individuals with Down syndrome, where symptoms commonly appear by 40 years of age. Pathological findings include diffuse cerebral atrophy with narrowing of the gyri, widening of the sulci, and dilation of the ventricular system. Neuritic plaques are present extracellularly, composed of a core of amyloid surrounded by degenerated neuronal processes. The amyloid in these plaques is derived from amyloid precursor protein, which is encoded on chromosome 21. Normally, amyloid precursor protein undergoes alpha cleavage, but abnormal beta cleavage results in the formation of beta amyloid, which aggregates and deposits in brain tissue. Beta amyloid may also accumulate around blood vessels, increasing the risk of cerebral hemorrhage. Another hallmark feature is the presence of neurofibrillary tangles, which are intracellular aggregates of hyperphosphorylated tau protein, a microtubule-associated protein that becomes disorganized. There is also a marked loss of cholinergic neurons in the nucleus basalis of Maynard, contributing to cognitive decline. Diagnosis is primarily clinical, made after exclusion of other causes of dementia, and is confirmed through histopathological examination at autopsy when possible. Vascular dementia. Vascular dementia results from multifocal cerebral infarctions and brain injury secondary to chronic hypertension, atherosclerosis, or vasculitis. It is the second most common cause of dementia following Alzheimer's disease. The repeated ischemic or hypoxic injury leads to progressive cognitive impairment and neurologic dysfunction. Pick disease. Pick disease is a degenerative condition primarily affecting the frontal and temporal lobes of the cerebral cortex, while sparing the parietal and occipital lobes. The disease is characterized by the presence of round cytoplasmic inclusions known as Pick bodies, composed of aggregated tau protein within cortical neurons. Early manifestations include behavioral changes and language disturbances, which gradually progress to global dementia as the disease advances. Parkinson's disease. Parkinson's disease is a degenerative neurological disorder characterized by the progressive loss of dopaminergic neurons in the substantia nigra of the basal ganglia. The nigrostriatal pathway, which relies on dopamine, is essential for the initiation and smooth execution of voluntary movements. This disorder is commonly associated with aging and affects approximately 2% of older adults. The exact cause is unknown, though in rare cases it has been linked to exposure to MPP, a contaminant found in certain illicit drugs. The classic clinical features can be remembered by the acronym TRAP, which stand for tremor, rigidity, akinesia, and postural instability. The tremor is classically described as a resting, pill-rolling tremor that diminishes with voluntary movement. Rigidity presents as cogwheel stiffness in the extremities, while akinesia or bradykinesia manifests as slowness in initiating movement and a reduced facial expression, often described as a mask-like face. Postural instability and a shuffling gait develop as the disease progresses. Microscopic examination reveals loss of pigmented dopaminergic neurons in the substantia nigra and the presence of round, eosinophilic cytoplasmic inclusions known as Lewy bodies, composed of the protein alpha-synuclein. Dementia often occurs in the later stages of Parkinson's disease. However, when dementia develops early in the course and is accompanied by visual hallucinations and Parkinsonian features, the diagnosis is more consistent with Lewy body dementia, in which Lewy bodies are present in the cerebral cortex. Huntington disease. Huntington disease is an autosomal dominant neurodegenerative disorder caused by expansion of a trinucleotide, cytosine adenine guanine, CAG, repeat in the Huntington gene located on chromosome 4. The condition is characterized by progressive degeneration of gamma-aminobutyric acid, GABA, producing neurons within the caudate nucleus of the basal ganglia, leading to loss of inhibitory control over motor pathways. The number of CAG repeats may further expand during spermatogenesis, resulting in anticipation, where symptoms appear earlier and progress more rapidly in successive generations. Clinically, Huntington disease presents with involuntary, irregular, rapid movements known as chorea, which later progress to cognitive decline, dementia, and depression. The average age of onset is around 40 years. Suicide is a common cause of death due to the progressive and debilitating nature of the disease. Normal pressure hydrocephalus. Normal pressure hydrocephalus is characterized by increased cerebrospinal fluid accumulation within the ventricular system, leading to ventricular dilation without a corresponding increase in cerebrospinal fluid pressure. This condition typically occurs in older adults and is often idiopathic. The accumulation of cerebrospinal fluid leads to stretching of periventricular fibers, resulting in a characteristic clinical triad of urinary incontinence, gait instability, and dementia, described as wet, wobbly, and wacky. Symptoms often improve following lumbar puncture, and definitive treatment involves placement of a ventriculoperitoneal shunt to divert cerebrospinal fluid and relieve pressure. Spongiform encephalopathy. Spongiform encephalopathies are a group of fatal neurodegenerative diseases caused by abnormal prion proteins. Prion protein is normally found in neurons of the central nervous system in an alpha helical configuration, referred to as PRP. In disease, it undergoes a conformational change to a beta-pleated configuration, designated PRP. This abnormal protein is resistant to proteolytic degradation and induces conversion of normal prion proteins into the abnormal form, creating a self-propagating cycle of neuronal damage. Microscopically, the brain shows spongy degeneration characterized by vacuolization within neurons and glial cells. The most common form is Creutzfeldt-Jakob disease, which usually occurs sporadically but can also be transmitted through exposure to contaminated human tissue, such as during corneal transplants or administration of human-derived growth hormone. The disease presents with rapidly progressive dementia, ataxia due to cerebellar involvement, and myoclonus triggered by startle. Electroencephalography reveals characteristic periodic spike wave complexes. The condition is invariably fatal, typically resulting in death within 1 year. Variant Creutzfeldt-Jakob disease is linked to exposure to bovine spongiform encephalopathy, also known as mad cow disease. Another related prion disorder is familial fatal insomnia, an inherited condition characterized by progressive insomnia, autonomic dysfunction, and exaggerated startle response leading to death. Central nervous system tumors. Central nervous system tumors can be either metastatic or primary in origin, each accounting for approximately half of all cases. Metastatic tumors typically present as multiple, well-circumscribed lesions located at the junction between gray and white matter. The most common primary sites of origin for metastatic lesions include the lung, breast, and kidney. Primary central nervous system tumors are classified based on the cell type from which they originate, such as astrocytes, meningothelial cells, ependymal cells, oligodendrocytes, or neuroectodermal tissue. In adults, primary tumors most often occur in the supratentorial region, with glioblastoma multiforme, meningioma, and schwannoma being the most common types. In children, primary tumors usually develop in the infratentorial region, where pilocytic astrocytoma, ependymoma, and medulloblastoma are the most frequent. Primary malignant central nervous system tumors are locally aggressive and destructive, but rarely metastasize beyond the central nervous system. Glioblastoma multiforme. Glioblastoma multiforme is a malignant, high-grade tumor derived from astrocytes and represents the most common primary malignant central nervous system tumor in adults. It typically arises in the cerebral hemispheres and often crosses the corpus callosum, producing a characteristic butterfly-shaped lesion. Histologically, it features regions of necrosis surrounded by densely packed tumor cells, a pattern known as pseudopalisading, along with marked endothelial cell proliferation. Tumor cells are positive for glial fibrillary acidic protein. The prognosis is poor despite aggressive treatment. Meningioma. Meningioma is a benign tumor that originates from the arachnoid cap cells of the meninges and is the most common benign central nervous system tumor in adults. It occurs more frequently in women and is rare in children. The tumor compresses the adjacent cortex without invading it, often presenting with seizures due to cortical irritation. Imaging reveals a well-circumscribed, round mass attached to the dura mater. Histologic examination shows a whorled growth pattern, and psammoma bodies, calcified concentric structures, may be present. Schwannoma. Schwannoma is a benign tumor of Schwann cells, which form the myelin sheath around peripheral and cranial nerves. It most commonly involves cranial nerve 8 at the cerebellopontine angle, leading to hearing loss and tinnitus. Tumor cells are positive for the S100 protein. Bilateral schwannomas are characteristic of neurofibromatosis type 2. Oligodendroglioma. Oligodendroglioma is a malignant tumor arising from oligodendrocytes. Imaging typically shows a calcified mass within the white matter, most often in the frontal lobe. Patients may present with seizures due to cortical involvement. Histologically, tumor cells exhibit a distinct fried egg appearance with clear cytoplasm surrounding central nuclei. Pilocytic astrocytoma. Pilocytic astrocytoma is a benign tumor derived from astrocytes and is the most common central nervous system tumor in children. It most frequently arises in the cerebellum. Imaging reveals a cystic lesion with a mural nodule. Histologic features include Rosenthal fibers, which are thick eosinophilic processes of astrocytes, and eosinophilic granular bodies. The tumor cells are positive for glial fibrillary acidic protein. Medulloblastoma. Medulloblastoma is a malignant tumor that originates from the granular cells of the cerebellum, which are of neuroectodermal origin. It primarily occurs in children. Histologically, the tumor consists of small, round blue cells, and homarite rosettes may be seen. Medulloblastoma has a poor prognosis due to its rapid growth and tendency to spread through the cerebrospinal fluid. Metastasis to the cauda equina is referred to as drop metastasis. Ependymoma. Ependymoma is a malignant tumor arising from ependymal cells and is most commonly seen in children. It typically develops in the fourth ventricle, where it may obstruct cerebrospinal fluid flow and cause hydrocephalus. Histologic examination reveals paravascular pseudorossettes as a characteristic finding. Craniopharyngioma. Craniopharyngioma is a benign tumor derived from epithelial remnants of Rathke's pouch. It commonly presents as a supratentorial mass in children or young adults and may compress the optic chiasm, resulting in bitemporal hemianopsia. Calcifications are frequently seen on imaging because the tumor contains tissue resembling developing teeth. Although benign, craniopharyngiomas have a tendency to recur after surgical resection,